This lecture will briefly describe some of the infant pediatric conditions that the respiratory therapist may see and the cardiopulmonary interventions that may be helpful in the acute care, rehabilitation, and home care setting. Although most of the congenital cardiac defects require surgical repair, there may still be a need for cardiac rehabilitation as the child ages. Please review respiratory and cardiac development in utero in this chapter. We will start with congenital heart defects that have lifetime repercussions and therefore create a need for interventions at every level of the healthcare continuum. The first group of cardiac conditions we will look at are congenital heart defects. Diagnosis may be made during prenatal care, at birth, or during childhood. The incidence is approximately 6 to 8 per 1,000 live births. They are described as either cyanotic, meaning PaO2 is decreased, or acyanotic, indicating a normal PaO2. Acyanotic lesions include atrial, ventricular, or atrioventricular septal defects, patent ductus arteriosus, coarctation of the aorta, and pulmonary or aortic stenosis. Common cyanotic lesions include tetralogy of Fallot, transposition of the great arteries, tricuspid or pulmonary atresia, truncus arteriosus, total anomalous pulmonary venous return, and hypoplastic left-sided heart syndrome. Acyanotic lesions increase pulmonary blood flow so that fully oxygenated blood is shunted back into the lungs and body, also known as left to right shunt. Symptoms include sweating, increased respiratory rate, and heart failure. Atrial septal defects are most commonly caused by a patent foramen ovale, which usually closes after birth. Without closure, the baby will exhibit a heart murmur and enlarged pulmonary artery. Treatment is surgical correction. A patent ductus arteriosus is often associated with prematurity or Down syndrome. Symptoms include tachycardia, increased respiratory distress, and poor weight gain. Treatment includes surgical closure or IV indomethacin. Ventricular septal defects are characterized by one or more small openings in the wall separating the ventricles. Small holes may close on their own, but larger defects lead to bacterial endocarditis, pulmonary vascular obstruction, aortic regurgitation, and increased incidence of lower respiratory infections, or CHF. Surgery is indicated. Atrioventricular septal defects are also called atrioventricular canal defects or endocardial cushion defects, and are common in Down syndrome. Symptoms include pulmonary hypertension, lung congestion, and heart failure, and again, surgery is indicated within the first few months of life. Coarctation of the aorta is a narrowing of the aorta which impedes left ventricle outflow. Hypertension is seen in the upper body and normal to low blood pressure in the lower extremities. Cyanotic lesions are marked by decreased PaO2 and right to left shunt. This resultant hypoxemia results in polycythemia and increased risk of cerebrovascular insult. Tetralogy of Fallot is named because of the tetrad of defects which include pulmonary stenosis, VSD, overriding aorta, and right ventricular hypertrophy. The degree of cyanosis depends on the degree of pulmonary stenosis, and surgery is usually required. Hypoplastic left heart syndrome, HLLS, includes hypoplastic left ventricle, aortic and mitral valve stenosis or atresia, and often coarctation of the aorta. The child may develop severe CHF once the ductus arteriosus closes. Prostaglandin E1 may be given and mechanical ventilation may be required until surgery or heart transplant can occur. Transposition of the great arteries occurs when the positions of the aorta and pulmonary artery are reversed. Surgery is always indicated, and even with successful surgery, arrhythmias or ventricular dysfunctions may occur later in life. Tricuspid atresia leads to obstruction of blood flow into the right ventricle, and the right ventricle is often underdeveloped. Symptoms can include anoxia, sign of right-sided heart failure, severe cyanosis and dyspnea, and surgical repair is required. In pulmonary atresia, the pulmonary valve fails to develop, resulting in obstruction of blood flow from the right heart to the lungs. The presence of other cardiac defects such as ASD or VD would allow right to left shunting, and therefore allow blood flow to the rest of the body. Truncus arteriosus is where both the right and left ventricles empty into a single large vessel, which acts as one ventricle, and surgical repair is required. The last cardiac defect, total anomalous pulmonary venous return, results in pulmonary congestion, cyanosis, and heart failure, and surgical repair must be performed as soon as possible. Now, let's turn our attention to respiratory conditions of infancy and the need to provide interventions to improve quality of life as a child ages. The first condition is prematurity, which is defined as babies born prior to 37 weeks gestation. Babies may exhibit apnea or periodic breathing, which results in bradycardia and hypoxemia. Babies born prior to 35 weeks may not have produced surfactant and are at increased risk of hemorrhages. Lack of fatty insulation may result in increased oxygen consumption, and elastic properties of the lung and high oxidative fibers in the diaphragm are not fully developed, resulting in diaphragm fatigue and respiratory failure. Babies born before 26 weeks gestation may have underdeveloped capillary beds, leading to increased pulmonary vascular resistance and right-to-left shunting. Persistent pulmonary hypertension may result from a patent ductus arteriosus and result in increased pulmonary vascular resistance and symptoms of cyanosis, tachypnea, intercostal retraction, nasal flaring, or grunting. With respiratory distress syndrome or hyaline membrane disease, babies will exhibit respiratory rates greater than 60 breaths per minute, nasal flaring, intercostal and subcostal retractions, grunting on expiration, and peripheral edema. Meconium aspiration syndrome, MAS, may result from vagal stimulation and hypoxic stress during birth. Mechanical ventilation or supplemental oxygen may be required, and extracorporeal membrane oxygenation, or ECMO, may be required to manage severe MAS. Bronchopulmonary dysplasia, BPD, is a chronic respiratory disorder characterized by scarring of lung tissue and thickened pulmonary arterial walls and VQ mismatch. Supplemental oxygen, mechanical ventilation, and a need for ongoing multidisciplinary services will often be required. Cystic fibrosis is a genetic autosomal recessive disease that affects the exocrine glands. Although survival rates have increased dramatically over the years, median survival age is in the mid-40s, approximately 90% of deaths are due to pulmonary compromise. Airway clearance, ribcage mobility, postural drainage, and exercise, in addition to bronchodilators and mucolytics, are indicated. Pulmonary rehabilitation in the form of exercise, breathing techniques, pulmonary toilet, diet, and education greatly improve quality of life and improve symptoms. We will discuss this further in Lesson 12. Lastly, primary ciliary dyskinesia is a respiratory condition in infancy that may have lifelong implications and require programs to improve quality of life. Although rare, it is treated much like CF, with a rehabilitation program to include the same protocols. Our next lesson furthers our discussion.